Hello, everyone, and welcome to today's webinar, Time to First Expression, Improving Lactation Outcomes, Early Strategies for Preterm Mothers, and Dr. Leslie Parker, PhD, APRN. Before we get started, I would like to go over a few items so you know how to participate in today's event. By default, you have joined the presentation listening using your computer's speaker system. If you prefer to join over the telephone, just select phone call in the audio pane, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of today's presentation. There are also handouts available. Please be sure to download these before the end of the live event. Simply locate the handout section on your panel, click it, and click on the attachments. Today's webinar will be recorded and available at Medelia University and Medelia's Education for Lactation Professionals YouTube channel. I would now like to introduce Leslie Parker, PhD, APRN. Dr. Leslie Parker's research involves nutritional support of the premature infant with an emphasis on breastfeeding infants in the neonatal intensive care unit. She has been funded by the National Institute of Nursing Research to study the risks and benefits of routine gastric residual aspiration and evaluation in very premature infants and the optimal timing of initiation of milk expression following the delivery of a very premature infant. She received a research opportunity grant in 2018 to study strategies to increase lactation success in mothers of extremely premature infants. She also received a University of Florida Term Professorship Award in 2017. Dr. Parker is board certified as a neonatal nurse practitioner by the National Certification Corporation. She has an active practice as a neonatal nurse practitioner in the NICU at University of Florida Health. Dr. Parker?
Good afternoon. Thank you very much for that nice introduction. And good afternoon to everyone, or I guess good morning, good evening, or good night, depending on where you are listening from. I'm really excited to discuss a topic that is near and dear to my heart, and something that is currently one of the main foci of my research. This is really concentrating on the first few days postpartum to help mothers of preterm infants optimize their lactation outcomes, including when should we initiate expression or pumping after delivery. So our objectives are to describe the most recent research regarding time to initiation of breast pumping after delivery, understand early strategies to improve lactation outcomes in mothers of preterm infants, and to describe best practices for lactation support during the first few days postpartum. My only disclaimer is that I am funded by Medelia for some of the research that we do in our lab. So I think all of us are completely aware that breastfeeding or consumption of mother's own milk in the case of pump-dependent mothers who must use a pump to obtain milk for infants who are too immature or too ill to breastfeed. Mother's own milk is critically important for neonatal health. In fact, for infants in the NICU, we consider mother's own milk to actually be a medication. If you think about it, what medication do we provide to infants that is more beneficial than mother's own milk and has zero potential side effects? Antibiotics? No. Think about all the side effects that are related to the use of antibiotics. What about Lasix? Lasix is associated with metabolic bone disease. I would suggest that mother's own milk should be considered a powerful drug. And in my NICU, we actually use this verbiage when we discuss with mothers the need for them to pump for their infants. And we start this process antenatally with both the neonatal team and lactation consultants, meeting with mothers, if at all possible. Now, obviously, some mothers are going to deliver before this opportunity arises. But oftentimes, mothers are in labor and delivery for days before delivery, and this provides an ample opportunity for actually consulting with the mother and providing them some information. Now, some people have asked me, don't you think that this is going to make mothers feel pressure to pump or guilt if they decide not to provide their own milk? And I really 100% disagree with this. We don't pressure mothers, but we provide clear, concise, and evidence-based information regarding the benefits of mother's own milk to their infants. In my opinion, mothers deserve this information. They need this information in order to make an informed decision. And in fact, there's literature that shows moms want this information and are angry if they don't receive it, and don't feel pressure and don't feel guilt if they receive this information. So it's also important for mothers. Not only does it improve their short and long-term health, it also provides mothers an opportunity to feel that they are providing something to their infant that no one else can. This is so important because oftentimes mothers are not able to provide any of the typical mothering activities when their infant is critically ill in the NICU. And providing their own mother's milk can empower them to feel like they are an important part of their infant's neonatal care. Think about all the mothering opportunities that we as providers kind of steal from them. We don't allow them to diaper. We don't allow them to breastfeed. We don't allow them to bathe their infant. Obviously, if they're very critically ill, we don't allow this to happen. So these are very important. And this was one of the mothers in one of our research projects that said, I felt like I was helping him get healthy. How empowering is that for our moms? So as you are well aware, mother's own milk contains some pretty amazing components, including secretory activation, secretory IgA, and this is highest in colostrum. And one of the things I think is the most amazing thing is this is also higher in mothers of critically ill infants. And it continues to astound me how mother's own milk actually adapts to the needs and the environment of the infant of the mother. In addition, it contains lactoferrin and lysozymes, which are major contributors to the reduction in infections seen in infants fed high doses of mother's own milk. It also contributes to intestinal maturation. When infants are in utero, they continually consume amniotic fluid, and amniotic fluid contains growth factors and hormones such as epidermal growth factor, GCSF, and epigen. And these factors are critical for maturation and development of the fetal gastrointestinal system. If infants are born preterm, they miss out on this amniotic exposure. And if we think about it, what is the closest element to amniotic fluid? It's mother's own milk, especially colostrum. However, this exposure is limited due to factors that routinely occur when preterm infants are admitted to the NICU, including delays in starting feeds, feeding minimal amounts of mother's own milk, and the use of donor human milk in those first few days. And donor milk is much superior to formula, but it does contain less protective elements related to the need for pasteurization. And so the end result, if they aren't exposed to these factors and hormone, is potentially a decrease in gastrointestinal development and maturation. And I think it's possible that this may later on be related to a increased feeding intolerance. And if you work in the NICU, you are well aware that probably the vast majority of preterm infants at some time or another will experience feeding intolerance. Mother's own milk also contains oligosaccharides, and these are essentially prebiotics which encourage colonization of the infant's GI tract. with beneficial rather than potentially pathogenic bacteria. Mother's own milk also contains a unique microbiome containing specific healthy bacteria that colonize the infant's intestines. And as you look at these columns, you can see they're in columns of 3. And each one of those columns of 3 is an individual mother's microbiome. And each one of those 3 columns represent a different time point. And if you look at this schematic, this is 16 different mothers. And as you can see, each mother is very different from each other. However, even over time, a specific mother, an individual mother, continues to have a pretty similar microbiome of her milk. It doesn't change much over time. And both oligosaccharides and the beneficial bacteria in mother's own milk decrease the number of pathogenic bacteria present in the infant's intestines. And this is important because we know that intestinal microbial dysbiosis increases an infant's risk of complications. So one of the things we have to consider is if we have pathogenic bacteria within the intestines, it has the opportunity to invade the bowel wall. So what these are enterocytes within the intestinal border of a preterm infant. And usually, and in a healthy, for hopefully mine and yours, our intestines between those enterocytes, there's a very tight and closed tight junction. And this does not allow any bacteria from inside the intestines to invade the intestinal wall. But what happens to our preterm infants and our critically ill infants is oftentimes these tight junctions are open, and this can allow bacteria that is inside the intestines to invade the bowel wall and potentially be translocated into the infant's circulatory system. So the reason that we want nice beneficial bacteria in the infant's intestine, such as that which is in mother's own milk, because we know that intestinal dysbiosis or pathogenic bacteria within the intestinal system of preterm infants predisposes them to necrotizing enterocolitis and sepsis. So we really want to maintain that healthy microbiome. Mother's own milk also contains anti-inflammatory components such as prostaglandins, antioxidants, anti-inflammatory cytokines, and platelet activating factor acetylcholedase. And this last one is very important because we know that platelet activating factor is important in the development of necrotizing enterocolitis. And platelet activating factor acetylcholedase actually inhibits the activity of platelet activating factor. So again, intestinal inflammation is also very important in predisposing infants to some of our most complications that increase morbidity and mortality. And so if we have an inflamed intestinal wall, it increases the risk of both necrotizing enterocolitis and sepsis. So again, we want to make sure that those intestinal microbiota are beneficial. Last but not least, mother's own milk contains stem cells, and these essentially have the potential to develop into any type of cell. In animal models, milk stem cells have actually been found in the brains of adult rats. And this suggests that not only could these stem cells positively affect the health outcomes during the neonatal period, but they have the potential to impact health throughout the infant's life. And this is just the tip of the iceberg. Not only did I not go over everything that there is in mother's own milk, we continually find more and more components that we never knew about that are actually in mother's own milk. However, I do have one caveat to that. I strongly believe, and many researchers are currently studying the components in mother's own milk. However, I would argue that that's kind of irrelevant. I don't really care what's in mother's own milk if I don't have enough mother's own milk to get into the baby for those components to have some benefit. So not only do we need to study what's in breast milk or mother's own milk, we also need to study how to increase the ability of mothers to meet their lactation goals. So I'm briefly, I'm going to go over a couple of slides about why we want mother's own milk in the preterm population. Well, first off, we know that it decreases the incidence of bronchopulmonary dysplasia. And this is important because bronchopulmonary dysplasia has a high risk of increased mortality and morbidity in the preterm population. It also decreases the risk of retinopathy of prematurity. And retinopathy of prematurity is a significant factor which can impair the visual acuity of preterm infants. We've already discussed that it reduces the risk of necrotizing enterocolitis as well as sepsis. But it also does some other amazing things. It decreases cost of care, decreases the risk of rehospitalization, decreases the risk of feeding intolerance, and improves neurodevelopmental outcomes. And this is especially important in our preterm population who are at such high risk of neurodevelopmental delays. However, we know that pump-dependent mothers of preterm infants in the NICU often struggle to provide sufficient amounts of mother's own milk to provide these well-known benefits. And these barriers include delayed secretory activation, suboptimal pumped mother's own milk volume, and a shortened lactation duration. We also know that up to 90% of mothers produce insufficient amounts of mother's own milk to provide exclusive feedings during NICU hospitalization. And when you think about it, the benefits of mother's own milk are dose dependent, with increases in dose as little as 10 cc's per kilo per day, significantly reducing the risk of complications. So essentially, every single drop of mother's own milk matters. We also know that only 38 to 52% of mothers lactate until their infant's NICU discharge, and even fewer of those lactate for the recommended 12-month duration. So mothers of preterm infants are at high risk of delayed secretory activation. And this is probably a better word for lactogenesis stage 2 or milk coming in. Now, in mothers that deliver healthy, full-term babies and are breastfeeding, the definition of delayed secretory activation is an onset greater than 72 hours postpartum. However, in the preterm population, 65% of mothers have a delayed secretory activation. And we have found, as well as others, that mothers oftentimes have a secretory activation onset at about 5 to 5.5 days, much later than our term healthy breastfeeding mothers. So the other thing that often happens in this situation is that many of these mothers of preterm infants pump just drops for the first several days after delivery, because in the NICU, we generally want to start feedings in preterm infants soon after delivery. This delayed secretory activation can have some pretty significant negative consequences, including a delay in initiation of feeds. And this is important because we know that lack of feeds can quickly result in significant intestinal atrophy and dysfunction. In addition, a delayed secretory activation can result in starting feeding formulas, which we also know is not good for an infant's intestines. Finally, when secretory activation is delayed, infants are often fed donor human milk. While obviously donor human milk is better than formula, it is nowhere as beneficial as mother's own milk, especially colostrum, in those first few feedings in the first few days. In addition, mothers that have delayed secretory activation have decreased milk volume production, both short-term and long-term, as well as a shortened lactation duration. So essentially, my team has spent the last decade working to develop strategies to help mothers optimize their lactation outcomes, because we want moms to pump so much milk that they have to use a cart to take all their milk home when their infant is discharged. However, these mothers are at significant risk for factors that are known to negatively affect lactation, including a high risk of comorbidities such as diabetes, hypertension, high BMI and obesity, high rates of C-section, immature mammary development, maternal stress, and maternal infant separation. So since many of these factors are non-modifiable, we can't change them. What we need to do as clinicians is think about what can we do that is modifiable? How can we help mothers to be more successful with these modifiable actions? And one of those actions is the time to initiation of pumping postpartum. So when we take a look at what some of the recommendations are, they're a little bit confusing. So Baby Friendly Hospital Initiative recommends beginning lactation within 2 hours postpartum. However, the Baby Friendly Initiative United Kingdom recommends starting lactation 1 to 3 hours postpartum. And then the Baby Friendly Hospital Initiation for neonatal wards really doesn't specify when we should be starting initiation. So the question remains, what is the evidence regarding time to initiation and what should we be doing in our practice? So when we look at the evidence in term breastfeeding mothers, we can see that mothers that start breastfeeding within 2 hours are more likely to have a higher mother's own milk production at day 4 postpartum. Additional research shows that if you wait over an hour postpartum, mothers are more likely to have an earlier lactation cessation. And compared to 46 hours, if moms begin breastfeeding within 10 minutes, they are more likely to have a longer duration of breastfeeding. But I would suggest that pump-dependent mothers of preterm infants are likely different. And I think that it is not what we should be doing by taking what we do in term infants and just bringing it down to those mothers in the NICU that are pump-dependent and who have delivered a preterm infant. So I really decided to determine exactly what we should be doing. When should we start pumping after delivery? So I started out with a pilot study, a very small pilot study of 20 moms. And I randomized them to start pumping within 1 hour after delivery or within 6 hours after delivery. And what we found is if mothers started pumping within 1 hour after delivery, they produced significantly more milk for the first 6 weeks postpartum and had an earlier achievement of secretory activation. And so I decided to look at this in a bigger study so that we really had some good evidence upon which to base our clinical practice. And I was lucky enough to be funded by the National Institute of Nursing Research to do a randomized controlled trial. So we enrolled 180 mothers before they delivered. And these were mothers that delivered an infant less than 33 weeks gestation and who weighed less than 1,500 grams. And we randomized them into one of 3 groups. One group initiated milk expression within 1 hour after delivery. One group initiated pumping within 1 to 3 hours, and one group initiated between 3 and 6 hours. And the outcomes that we were looking for was pumped mother's own milk volume for 6 weeks, time to secretory activation, and lactation duration. And what we found was not exactly what I wanted to find. So we actually found that mothers in the late expression group, those that started milk expression between 3 and 6 hours, made more milk almost the entire 6 weeks. And this was actually statistically significant in those first 5 days. And we looked at the onset of secretory activation. And this again was longer in those moms that started pumping within 1 hour. And actually the immediate group, which started pumping between 3 and 6 hours, had nearly a significantly earlier achievement of lactogenesis stage 2 or secretory activation. Days lactated, there was no difference between groups. And when we looked at the percentage of mother's own milk consumed by infants, there really was no difference. So as you can imagine, I was so disappointed. I had known from my pilot study that those moms that started pumping within 1 hour were going to do so much better than any of the other groups. And so I was like, where do I go from here? This isn't what I expected. This isn't what I hypothesized. And so I went in a little bit and I dug deeper into what was going on with this cohort of mothers. And I found there was a significant difference between mothers that started initiating expression at 3 to 6 hours. They actually pumped more often during those first 5 days postpartum. And I really started thinking that this was a package. So it wasn't okay, you start out, you initiate expression, and then you're done. And those that start early are going to do great. It's a package. Moms need to start early and they need to be pumping frequently. And it's the most important during those first 5 days postpartum. But real life is really not conducive sometimes to early initiation of pumping postpartums. Most mothers who deliver preterm will need assistance with pumping early after delivery due to C-section, being treated with magnesium, and other health conditions. And usually it's the nurse who assists the mothers with that initial pumping. But this is often delayed past 6 hours postpartum. And we wanted to understand what was going on. So we did a survey of obstetrical nurses throughout the state of Florida to find out what were some of their barriers to early initiation of milk pumping. And what we found was that they were hesitant to pump mothers due to their acuity, and they were concerned about pain and stress and whether this early pumping would cause an increase in the mother's pain and an increase in her stress. And when we dug down a little bit deeper, the acuity level that the nurses were concerned about was mothers that had preeclampsia and mothers that were on magnesium sulfate for preeclampsia. And I think this is really conducive to some education, because if we think about the physiology of lactation, we know that lactation is associated with an increase in oxytocin. And we know that oxytocin actually decreases blood pressure. So it's likely that this pumping soon after delivery was not going to make your preeclampsia worse. And we did look at pain and stress in our previous research. And we found that mothers that started pumping within 1 hour after delivery actually had less pain and less stress than mothers that started pumping later. The other thing that's a little bit more difficult is the lack of time and the lack of personnel to be able to assist mothers with that initial pumping. So I started thinking about this a little bit more, and I started thinking, do we really need a registered nurse to help moms with that first pumping? Could it just be a family member that helped them? And this is no way to say that the nurse or the lactation consultant isn't imperative for all of the education that comes afterwards. But in that first few hours, could a family member be the person that helps these mothers to initiate expression? And so what we decided is, could we educate someone else to assist mothers with this initial pumping session? And in order for this to be effective, this education would need to begin before the infant was born. Because if we wanted them to initiate soon after delivery, it was too late to start educating after delivery. And this is actually very feasible because, again, mothers that deliver preterm are oftentimes in labor and delivery for days before delivery, and they want to learn how to meet their lactation goals. So we started looking at who that support person might be. And it could be the mother's mother, her aunt, her friend, her husband, her boyfriend, her wife, her girlfriend. It could be anyone that that mother considered to be her support person and that she thought would be there when she delivered. Because I don't think that first initial expression is really just for stimulation of the breast. I don't think it's rocket science, and I think family members and support persons can be educated to perform this duty. So what we did is we enrolled 61 mothers and their support persons, and these mothers were in the antenatal enrollment and consent, and they were at risk for delivering infants that were less than 35 weeks gestation. And we randomized them before delivery into one of two groups. In group one, we gave a very, very intense education session to the mother and her support person regarding the importance of early initiation of pumping and how to use a breast pump. And we actually took a breast, a fake breast, obviously, and we let them practice on this fake breast, on how to put the shield on, how to pump, how to turn on the pump, and everything related to that. The other thing that we did is we put a completely ready to go breast pump in their hospital room. So the minute that mother delivered, she would be able to start and have the equipment necessary to start pumping her breasts. And group two just really had standard care. So whoever happened to be there to help her pump, and if the pump was there or not, was really dependent on just the standard of care. And so what we found was there was really no difference between the intervention group and the control group. So moms in the intervention group pumped 4 hours after delivery, and those in the control group pumped 3.8 hours after delivery. Not much of a difference at all. However, 19% of the support persons were not available immediately after delivery. And this makes sense because oftentimes these mothers deliver emergently. In the middle of the night, the support person may be at work, they may have other children to care for. But when that support person was available, the time to the initial expression was only 2.8 hours postpartum. In addition, if they were available, 10 of those support persons did not, for whatever reason, assist the mother to pump. However, if the support person was available, they were significantly more likely to assist the mother with pumping than anyone else. And I also thought it was very interesting that 11% of the mothers who received the education pumped themselves. Obviously, these were mothers who delivered spontaneous vaginally, but still, with education and access to a pump, they were successful in independently pumping after delivery. We also found that mothers whose support person received antenatal education pumped significantly more often during those critical first 5 days postpartum. And this is important because mothers often need assistance beyond that first pumping session. And it is possible that the support person assisted them to pump more often during those critical 5 days. Frequent breast pumping, it's clear that frequent pumping, especially in the first 5 days, is critical to optimize lactation. But the big question is, how do we do this? When you look at the literature regarding breast pumping and interventions to help moms make more milk, you can see that the methods start out with, we provided instructions to the mothers to pump 8 to 12 times a day, but very few actually did that. In ours and others' research as well, mothers did far less, like they pumped around 3 to 5 times per day, which is far less than the 8 to 12 that they were counseled to do. And this is especially important right after delivery. So because frequent pumping is so important to optimize lactation, we have been working on strategies to encourage mothers to pump more frequently. One of these strategies has been to use biomarkers to help mothers to pump more frequently. We actually use the sodium level in mother's own milk as a biomarker of pumping frequency. So this schematic illustrates mammary epithelial cells. And as you can see, just like in the infant's GI system, the junction between the cells are closed. And this happens at the time of secretory activation, but Hoban and colleagues actually found that in preterm mothers, these tight junctions can reopen after closure, depending upon how often a mother pumps. When tight junctions are closed, sodium does not travel through the tight junctions and into the milk, and the sodium levels within the milk are low. However, prior to secretory activation, and when mothers do not pump frequently, tight junctions are open, sodium can enter the milk, and the sodium levels in mother's own milk are high. So we thought, can we use sodium levels as a biomarker of frequent breast pumping to empower women to pump more frequently? What if we actually provided this information to the mother via text? Would this information help her to remember the importance of frequent pumping and realize she may not be pumping in an adequate frequency and encourage her to pump more frequently? Perhaps this could also help mothers to have personalized lactation and not just a one-size-fits-all kind of approach. So to test this theory, we conducted a small pilot study of 50 mothers who delivered infants admitted to the NICU, and we randomized them to receive either enhanced text messages, and this included the milk sodium level, the number of times the mother pumped the day previous, as well as a little bit of information about her milk volume. Was it going up? Was it going down? Was it staying the same? And what we thought that would help her. So if her sodium level was going up, we would say, your sodium level is going up. It looked like you only pumped 2 times yesterday. Perhaps you could try to increase your number of pumping sessions to 8. The standard care group just received standard message, including things like how to clean a breast pump, how important mother's own milk is for the care of preterm infants. And our outcomes were measures of feasibility, number of pumping sessions per day, and lactation outcomes. And so what we found was days to the onset of secretory activation using a milk sodium level less than 20 did not differ between groups and were on average 4 to 4.5 days after delivery. And while this is higher than previously reported in mothers of preterm infants, remember this population also included mothers of term infants as long as they delivered an infant admitted to the NICU. We also found no difference in pumped milk volume over the first 14 days postpartum. What we did find was that more mothers in the intervention group were lactating at their infant's NICU discharge, and they pumped 9 days longer than mothers in the standard care group. And over the first 5 days, I just want to bring your attention to this. Median pumping frequency was statistically significant higher on day 5. But I also want you to take a look at this. Look how many times they pumped, between 4.8 and 5.1, way lower than that which the mothers were counseled, which was to pump 8 to 12 times per day. We also found mothers who received the biomarker-based text message were more likely to come to volume. And coming to volume is when a mother reaches at least 500 milliliters per day by day 14 postpartum. And coming to volume can be predictive of whether or not an infant is receiving his or her own mother's milk at NICU discharge. So 100% of the text message group and 85.7% in the standard group. And while this was not statistically significant, it could perhaps be clinically significant in this vulnerable population of women. And when we look at whether this intervention was feasible, we found it was. Mothers understood what the biomarkers indicated. It did not increase their stress level, which we were very worried about that. And they really loved receiving the text messages. So you can see we've done so much work, and it is so difficult to help mothers reach their lactation goals. Just seems like it might be too much work, and you might say to yourself, why are we going to do all this? We've got donor human milk. Isn't that good enough? And I would say a resounding no. And I want to look a little bit at, does donor human milk actually decrease the risk of complications? And yes, it does decrease compared to formula the risk of necrotizing enterocolitis. Compared to formula, it decreases the risk of NEC by 2.77-fold and decreases the risk of surgical NEC by 50%. But compared to mother's own milk, it does not decrease the risk of necrotizing enterocolitis. And what about all of those other benefits that we've talked about? It's kind of up in the air. We don't know if it decreases the risk of bronchopulmonary dysplasia. We know it decreases NEC. There's not a lot of information about ROP or sepsis. We do know that it decreases the cost, and this is related to the decreased cost of babies not having necrotizing enterocolitis. It may or may not decrease feeding intolerance. So while donor human milk has been shown to reduce feeding intolerance compared to formula, less feeding intolerance has been reported in infants receiving high doses of mother's own milk compared to donor human milk. We don't know about rehospitalization, but we do know that mother's own milk is associated with improved cognitive outcomes, and that this protection is dose related. However, a meta-analysis of 11 studies comparing donor human milk to formula found insufficient evidence to support the benefits of donor human milk in neuroprotection. And we know that higher neurodevelopmental scores have been found in infants fed mother's own milk compared to donor human milk. So yeah, it is important. We don't want to put all of our eggs in donor human milk. It's important, but certainly nothing compared to mother's own milk. I think we need to remember that this is not just a problem that mothers of very low birth weight infants face. It's a problem for infants, all mothers of all infants in the intensive care unit. And Ben Dixon et al. Actually found that in some situations, infants of lower gestational ages actually do better. Their mothers provide more milk. And this could potentially be because we're so focused on mothers of very low birth weight infant And we erroneously assume that, okay, well, she had a term infant, she'll be perfectly fine. We don't need to focus on that mother as much. And I would argue that, yes, we need to be focusing on the mothers of all infants in the NICU. So what are we as clinicians supposed to do? What at this point in time is the best evidence to provide our patients? It's pretty clear that mothers need to pump early and pump often. It's also pretty clear that mothers should start pumping within the first 6 hours after delivery, and probably the earlier the better. But they also need to pump more often. And this is a little bit tricky. How often should they be pumping? And should it be individualized for specific mothers? I don't think that we have enough information on how often mothers should pump. But I think we also need to recognize that pumping often right after delivery is critical. And so if we go into a mother's room and say, hey, it's time to pump, and the mom says, I'm tired, I think we need to provide them more information. We can't just accept that. We need to say, good afternoon, it's time to pump. And if she says, I'm tired, you can say, I understand that, but we have good evidence that you need to pump oftentimes in these first 5 days. And in order for you to have long-term sufficient milk supply for your baby, can I help you? And if they're still too tired, obviously that's their choice. But we need to provide them the evidence on which for them to make their own decisions. So is it worth the effort? I say 100%. If we think about the dose-dependent benefits of mother's own milk, we know it's good for infants of all gestational ages, and it's good for moms. Of course, it's worth the effort. And thank you very much. I do apologize for all of the technical issues, but we made it. So thank you for your attention.
Perfect, Dr. Parker. Give me just one moment here. And thank you so much for the presentation. We're going to begin answering the questions submitted during the presentation. Just a reminder that you can continue to submit questions through the questions pane in your attendee control panel. We still have about 10 minutes for those questions. So let me get the first question up here. And perfect. The first question is, we struggle with frequency of pumping on our unit. Do you have any recommendations on supporting moms to pump more frequently despite staffing challenges?
And that's the key point, staff challenges. And again, can we assist our family members and our support persons to help them to assist the mother? Can we help make it easier for the mother to do it by herself, having everything ready for her so that she can just pull the phalanges over to her and pump her breast, and have somebody else move the milk from the pump, move it into the bottles and all of that stuff, clean that up. But I do think that we need to help mothers, and I do think that I do recognize that there's staff challenges, but a lot of times these moms can't do it themselves, just because if we think about magnesium, we think about how sick they are, we think about how many of them have had a cesarean section. So yeah, it's really challenging.
Perfect, thank you. Another question is, how do you measure the milk sodium levels, please?
Oh, that's a very good question. We actually use it with a small device that you just put a drop of mother's own milk, and it will tell you the sodium level. And it's just a handheld. It looks almost like, this is kind of weird, but it almost looks like a pregnancy test. It's about that size. So very, very easy to do.
Perfect, thank you for that. What suggestions do you have for moms who pump only when the questions come in, it shifts everything. Bear with me. What suggestions do you have for moms who pump only a drop or two when pumping? I tell my moms not to worry about the amount that they are pumping to protect their supply and not to worry about the amount pumped each time. What other encouraging words do you have for these moms?
I always talk about those drops are so important, and we're gonna use those drops to put them into your baby's mouth. And this has the potential to be able to improve your baby's health. So every single drop counts. And I think also counseling moms that this is 100% normal, that oftentimes mothers produce nothing for almost 5 days after delivery. But regardless of how much they pump, each time they stimulate their breasts, they are providing the opportunity to have more milk for their babies later on. And really, when those they get very little, talking about the dose dependent, even a few drops can help your baby.
Perfect. Another person mentioned, hello, thank you for the presentation from Chile. I need to know the normal sodium levels in the breast milk.
So that's a very good question, and that's something that we don't really know 100%. It's probably, and this is probably, less than 20 or less than 16. And those are what have been studied in mothers of term infants, looking at tight junction closure related to achievement of secretory activation. So is this different for mothers of preterm infants? Possibly. And that's one thing that we are currently looking at is what should a normal sodium level be for a mother that's delivered a preterm infant.
Okay, thank you for that. Thinking of adding a pumping row in EPIC to increase accountability for RNs to assist in the first few days. Thoughts?
Oh, that we have been trying to do that. We have been like thinking, well, and this is for a postpartum unit, if they need to chart the feeds, if a mom is breastfeeding, they chart the feedings. So it seems just as important to chart the pumping. And we've had a little bit of a challenge actually incorporating that into EPIC. So if we use EPIC. So if you figure out how to do that, please email me and tell me how you did it, because I think that is a wonderful, because you can go back and see this mom only pumped 3 times, and you can use that as part of a quality improvement project to really see how is your unit doing, what are the obstacles, and can we improve it? And if you make a change, you can see whether or not you increase the pumping frequency of the mothers on your unit.
Perfect. In your RCT about timing of first expression and milk production at different intervals, were there any correlations between timing of first express and breastfeeding establishment or breastfeeding duration rather than qualification of milk volumes at intervals?
So we did collect data on breastfeeding. So remember that these babies were born less than 32 weeks. So moms initially had to start pumping. The babies were too young to really have the ability to fully breastfeed. But we did use that information, and we looked at some of the information that other people have shown, that as we progress with our breastfeeding, those babies that really started at the breast did better and breastfed longer than babies that started with a bottle. So in my institution, usually babies start on the breast, even if they're not ready to start bottle feeding, we start them on the breast for a good week before we start the bottle. And we found that those babies did much better breastfeeding and breastfed for longer.
Perfect. I think we have time for 1 or 2 more. What will be a precise answer for a mother who is asking how often and how long should they pump?
I may get into trouble for this, but I talk to mothers when I counsel them and really talk to them about what's going on in their lives and what we know. And sometimes I find that if we tell moms they need to pump 8 to 12 times a day, they're like, I just can't do that. There's just absolutely no way in the entire world that I'm going to be able to do 8 to 12 times. So when I have conversations and the mothers talk about that, what I don't want them to do is say, because I can't do 8 to 12 times a day, I'm just not going to do any. So we talk about what some of the literature has looked at, that 5 to 6 times per day might be enough to be able to sustain milk production. And so we talk about that. And I say, don't go less than 6 hours, but try to see what you can do as much as you possibly can. As far as how long they should pump, usually we do the typical counseling for 10 minutes or until your breasts have stopped flowing for a couple of minutes. But there's no, I think different mothers as far as length, how long they should pump is different for different mothers, and how long it takes for a letdown and how long it takes to completely empty the breast and things like that.
Okay, thank you. I think we're going to squeeze in one more if you're okay with that.
Of course.
Awesome. Could pumping be initiated prior to delivery for patients that are being induced or are in active labor?
Oh, I think that's a really good question, because we always worry about mothers of preterm infants pumping antenatally. But what you're talking about, because it can promote preterm labor, but you're really talking about if you're already saying, okay, it's time for this baby to deliver because they're being induced, that might be a different story. That's not a bad idea. I think that there'd be nothing wrong with that. And I think it would be perhaps empower moms to show that oh, I have a little bit of drops that I can feed my baby right after delivery.
Wonderful. Okay, that's all the time we have for questions. We will collect the rest of those questions and address them at another time via email. So thank you, Dr. Parker. Thank you to everyone for attending today's webinar, Time to First Express, Improving Lactation Outcomes, Early Strategies for Preterm Mothers. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email within 3 days with a link to the survey if you are unable to complete it now. On behalf of Medela and our presenter, thank you for joining us today and have a great rest of your day. Thanks, Doctor.
Thank you.